discussion that I had with Jane and with Irene. But John, thank you so much for being with us.
Thank you, Michael.
Both yesterday and today, and for your questions and for co-chairing that session. So maybe what I should do is I should sit back. I'll just introduce John Wort, who doesn't need an introduction, but John is the clinical lead of our PAH service, which has gone from strength to strength. And it's about, I think, 16 or 17 years that John joined us after finishing his PhD. He is a graduate from Oxford of chemistry and a graduate of medicine from UCL. And then your training, I think all of it here with us, and your PhD. And then it was Tim Evans who suggested, I mean, you worked on PAH on your PhD. And then we were probably a year or 2 years down the road of starting PAH as a designated center here. And then you arrived and you took the leadership of it. And we had Carl Harris, who is back with us, and you've taken the place, you know, to new heights. And we continue to work together because this is so good for the patients and for the learning. So John has a respiratory background and intensive care, critical care. So, but you know, he's in charge of the program which originally designated as congenital heart disease and now has idiopathic disease, has all the etiologies. Thank you so much, John. Off to you.
Oh, thank you very much, Michael. That's very kind. Yes, I'm a respiratory physician, so I feel slightly out of place in the inner sanctum of the cardiology world, but thank you for having me. And it's been a wonderful, wonderful meeting. I've learned a lot, so that's fantastic. So over to this plenary session then, and we've got some fantastic speakers and some really interesting titles. And we're going to start with Professor Wei Li, who I know very well from the Royal Brompton Hospital. She's an expert in integrated cardiac physiology in patients with ACHD and pulmonary arterial hypertension, using her vast echocardiographic expertise. She's contributed to many publications, textbooks, and has been integral to the development of several consensus statements for echocardiography and ACHD. She's head of our ACHD echocardiography service, and certainly my go-to person when I have patients with difficult echoes. So Wei's going to talk to us today about the right ventricular evolution and PAH-CHD. So thank you, Wei.
Thank you, John, for your kind introduction. I'm sorry, I think I'm mainly going to talk about adaptation rather than the evolution. I think evolution is a bit hard to talk, and hope it's still relevant to our audience. So now, without delay, I hope I can share my talk. Can you see my talk?
Yep. We can.
Okay. Is that a full screen?
It is a thing, Wei, yeah.
Okay. So as I said, I'm going to talk about right ventricular adaptation through in the congenital heart disease and PAH. So we see. Why this? Sorry, I can't control my screen. Oh.
You may see some arrows at the bottom left of your screen, Wei. Look at the bottom left within the slide. Within your slide, you may see something. Usually it's down there that you can advance. No?
Now, can I come out and reshare?
Or can Yanis advance it for you?
Yes, sorry. I should reshare. Oh, I'm really sorry this happened.
Anyway, it's no problem.
Okay. That's better. Now you can see better?
It hasn't come up as yet, but it may do. Let's wait. Not as yet. It's not. Have you shared it with us?
I shared.
Wait, okay.
Okay,
Let's go back.
let's go. Share.
Yeah, just.
Can you see?
It's
Yeah.
coming up now. That's good.
Better. That's okay, yeah?
Yes, let's see whether you can advance. Try.
Yeah.
There you are. Fantastic.
Yeah, good.
Off you go.
Thank you. Yeah. We see the ability of right ventricular adaptation to raise the afterload is a major determinant of clinical presentation and disease progression. In PAH, right heart failure is a consequence of raised afterload and not mere consequence of myocardial disease. The interaction between the intrinsic ventricular function and afterload, it's also known as coupling, is particularly important in determining ventricular adaptation. So we can see this in a normal heart. The right ventricular shape is very complex. In contrast to ellipsoidal-shaped LV, the RV appears triangular from a view from the side and crescent-shaped when viewed in a cross-section. The RV septum is concave, that curve inward like an hourglass. Now with the 3D reconstruction picture, we can really measure accurately the curvature. And this septal curvature is a useful matrix in pH, reflecting both the interventricular pressure gradient and the relative intraventricular size, as well as desynchrony of contraction. Furthermore, the anatomical angle between pulmonary trunk and the proximal ascending aorta and between RV inlet and the outlet tract are approximately 37.5 degrees in normal heart. This is known as golden angle, which determines optimal pump efficiency. The complex anatomy of right ventricle, as well as its myocardium fiber architecture, supports the unique role of this angle in preserving the peristaltic circulation inside the right heart. With severe disease like PAH, combined RV cavity enlargement and remodeling result in loss of normal architecture, contributing to intractable the RV pump decompensation. So in PAH, RV afterload increase due to progressive remodeling and proliferation of pulmonary vasculature. To preserve the cardiac output, thus systolic function, the RV initial adapts by increasing its contractility via the enhancement of intrinsic contractile property and via muscle hypertrophy. However, as the load progressively increases, the hypertrophic response will be hampered and a vicious circle of RV dilatation, systolic and diastolic dysfunction ensure. Several mechanisms could play a role of transition from an adaptive to maladaptive status, including genetic factors, neurohormone overreaction, and ischemia. Many research has been done in recent years in these fields, but the course from adaptive RV failure varies between individual and between different etiology. It is difficult to predict how long it will take. So far, we are unable to predict how long it takes to change from adaptive hypertrophy to RV failure. We think RV adaptive process depends on degree, time course, and of the time of the onset of pressure overload. Good example of various time course is congenital patient with isomonger VSD and a patient with COVID we recently seen. On the left, this patient with VSD can often have, you can see they often have an adaptive form of RVH and remain clinically stable with preserved cardiac output for decades, while despite similar elevation in RV pressure, actually in COVID, this patient's RV pressure possibly is only 2/3 of systemic, but had a mild history of 2 weeks, then developed rapid decomposition. We don't know what is the reason, but given the fact that right heart failure in PH is a consequence of increased afterload and not the mild consequence of myocardial disease, the ventricular pressure volume loop analysis is central in understanding RV physiology. Adaptive ventricles usually have preserved ventricular arterial coupling, while maladaptive ventricles usually have uncoupled ventricles. So when they are uncoupling, that means there is a reduced stroke volume due to increased pressure and also increased end-systolic volume, hence reduced the coupling. From this graph, you noted the RV uncoupling only occurs when the RV volume doubled or even tripled than that of normal. So during compensating period, patient may only minimally symptomatic. So how can we monitor the disease progress is often a clinical question. Fortunately, RV to PA coupling had a good correlation with ventricular function. Correlation with the coupling had a high correlation with fraction area change, which is 0.85. This is very good. So that means imaging can be highly accurate and useful in monitor disease progression. So indeed, this publication from Professor Nihoyopoulos' group from Hammersmith has studied 88 patients with 46 PAH and 42 chronic thromboembolic PH have shown that RV parameters approaching systolic function, including global and free wall longitudinal strain, RV fraction area change in TAPC and tricuspid S-wave, had an excellent ability to classify patients at high risk according to percentage predicted VO2 max. So this is also according to the ESC guideline. PAH patients are considered at high risk for clinical worsening or death when peak VO2 less than 11 mL per minute per kg. So this study has shown the RV function and the clinical presentation are correlated. So another important feature is RV desynchrony. It is most severe form of dysfunction with reversed septal motion and prolonged RV systole contraction during early diastole. When mitral valve opens, RV is still contracting, resulting in RV pressure of 20 to 30 millimeter mercury. This can transfer to LV and hamper both RV and LV failing. The relatively prolonged systole will be magnified when patients develop tachycardia, like here. Prolonged systole and very short diastole with the heart rate merely 110. This results in dramatic reduction in RV failing and hence reduction in cardiac output. So not surprised, patients like this will present dizziness and syncope. And mechanical desynchrony has been demonstrated by MRI study both using myocardium tagging and harmonic phase strain. Compared to LV, RV reaches the peak shortening much later than left ventricle. So RV asynchrony can be simply measured by systolic diastolic ratio from tricuspid Doppler wave here. You can see in the middle, we take the total right ventricular TR duration as systole and between the TR for the RV filling time as diastole. The ratio of the two, we call the systolic diastolic ratio, has a prognostic value. On the left is our study in 96 idiopathic PAH. Systolic diastolic ratio more than 1.1 predict worse survival than those with ratio less than 1.1. And previously in our Eisenmenger study, we have used the SD ratio more than 1.5. Together with the TAPSE and right atrial diameters are very sensitive in predicting the prognosis. So as disease progression, we know TR is the result of further RV deterioration and had a significant additive effect for patient outcome. Here is a study based nearly 90 patients with PAH. You can see one patient developed tricuspid regurgitation. The shape of the RV is totally become spherical. And also TR plus mean PA pressure more than 45 millimeter mercury had a lowest event-free probability as compared to patients with no TR or TR with less mean PA pressure. So clinically, it is very difficult to predict the time course from adaptive to maladaptive, as it varies tremendously. We have seen RV reverse remodeling and alongside improved survival with advanced therapy. So this study from the review registration have included nearly 2,000 patients with idiopathic PAH and hereditary PAH and patients with congenital heart disease, including Eisenmenger and also repaired congenital heart disease. So majority of them is IPAH. Only less than 1/3 is congenital heart disease related PAH. We can see at 4 years follow-up from enrollment, survival rate are similar between groups. At the 7 years from right heart cath diagnosis, although no statistic difference in survival rate, but idiopathic group have reduced survival as compared to those of Eisenmenger and repaired congenital heart disease patient, although they say it's not reached the statistical level. But we can see the line, the bottom black line of the IPH is clearly separating from the congenital group, despite absolute survival rate have improved compared with the pre-treatment era, maybe before the survival rate at 7 years will be about 35%. So we are going to ask why there is a difference with congenital patient and patient with idiopathic PAH. Here is the cross-section study prospectively enrolled patients with IPAH and congenital heart disease with increased RV afterload, pulmonary stenosis, and systemic RV using CMR, echo, and cardiopulmonary exercise testing. So at the bottom, you will see in PH patient, apical transverse and RV free wall motion was lower, and RV free wall shortening was prolonged, resulting in post-systolic shortening that was demonstrated on speckle tracking study, and intraventricular desynchrony. So also PH patient, if you look on the graph, it's the bar with a blue color, you can see have the highest EDV, ESV, and wall stress, lowest RV stroke volume, EF, and mass volume ratio. And RVs of patients with pulmonary stenosis, which is shown on the graph is red, are hyperdynamic with the lowest RV volume and supernormal RVEF, despite sustained substantially elevated RV pressure for several decades, suggesting RV-PA coupling is better when there is no pulmonary vascular disease. Unfortunately, in this study, there is no patient with Eisenmenger. So here is our study. We studied a total 83 patients, 43 of Eisenmenger and 40 with other cause of pulmonary hypertension. So there are significant differences in echo parameters between the two groups. The most important finding is RV in Eisenmenger patient had a higher free wall transverse strain and predominant apical strain. So this circumferential contraction usually seen in morphological LV and not RV. Furthermore, transverse strain is higher in post-tricuspid patients like VSD than pre-tricuspid lesions patients in ASD. And the transverse strain is an independent predictor for survival. You can see on the top, there is, if the strain more than 22%, patient had much better survival. This may explain the survival advantages in Eisenmenger patients. Higher or preserved transverse strain likely has its anatomical basis. From this heart specimen, Professor Ho have shown us the thickened RV wall has 3 layers of myocardium, except subepicardial and subendocardium. There is mesocardial layers of muscle, which resembles of LV architecture. So physiological difference in Eisenmenger syndromes, there is also existed between the different types of Eisenmenger. So compared with pre-tricuspid shunts, patient with post-tricuspid lesion, here we included VSD, AVSD, PDA, and AP window. This post-tricuspid lesion patient had less dilated RV, better RV function and coupling, higher stroke volume, and lower right atrial pressure. The RV function indices were best in patients with complete AVSD. You can see from all the graphs with gray bars. So all function parameters are better in AVSD than VSD. This may be attributed to early development of PAH during infancy in patients with complete AVSD. A lot of them have Down syndrome. This predisposing to early development of pulmonary vascular disease when the right ventricle maintains some characteristics of fetal phenotype. Moreover, the additional atrial shunt in patients with AVSD is likely to allow better diastolic offloading of the RV, albeit at the expense of cyanosis. So pre-tricuspid lesion like the ASD compared with post-tricuspid, they usually have prominent RV dilatation dysfunction, high right atrial pressure. The mortality also high when you compare a patient with age more than 48 years. So their clinical course more resembles that of idiopathic PAH. The recent study by Judith et al. Has shown that Eisenmenger ASDs had larger defects than their controls, no BMPR2 identified, suggesting that prolonged exposure to an increased shunt magnitude alone or in combination with another yet unrecognized genetic mutation could lead to a pathological change seen in pulmonary vascular bed and eventual development of pulmonary hypertension. So, systemic RV is a unique patient group in congenital heart disease. Here is the true heart with CCTGN and TGA after mastered repair. RV shape is totally changed to more spherical. You see from this 3D image, the septum is totally become convex, bulging to the opposite direction of RV free wall. But the echo imaging of the RV quite often not consistently accurately reflecting their clinical presentation. Here is one of our patients at age 29. She's had a TGA mastered, but clinically she's completely asymptomatic with NYHF function class 1. She was sent to us to assess for the ventricular contractile reserve because she's planning to have a children. To our surprise, on the 2D imaging, we have found her RV fraction area changing only 8% and global longitudinal strain is -9. But when we look on the MRI reporting, the RVEF is 40, which is impaired, but is not that bad. So we did RV EF with the 3D, we got 35%. But recently we had this new software from Hungary University. We are able to analyze the RV in the 3 dimensions: longitudinal, radial, and anterior, posterior component. We find in this patient, it is the anterior posterior component, which is much better and contributed mainly to the better EF we have seen on the 2D imaging. So there is a lot to be done and a lot to learn. In summary, we say unique anatomy of RV enables it to become more adaptive to chronic afterload increase than to acute afterload increase. Ventricular arterial coupling is a special form of interaction in patients with PH. The difference in RV adaptation between congenital disease-related PH and IPAH may be the result of difference in intrinsic myocardium ability to increase its contractile force, better characterization of normal RV function, early dysfunction, and irreversible damage, and the prediction of time course are needed. Novel approach are required to show the clinical value of imaging for predicting response and to help tailoring therapy. Thank you for your attention. Thank you.
Thank you, Wei. That's a fantastic talk. And I think in terms of timing, I think probably it's best that we move on and then save the questions for the end. And I do encourage everybody to please add some questions on the question link and chat line. I think Michael